Hey everybody, my name is Christine and I'm speaking on behalf of Group 6, Bableen, Taylor, and myself. Today we will be discussing hyperlipidemia. Hyperlipidemia is a complex disease that, if left untreated, can lead to atherosclerosis and the development of cardiovascular disease. There are two broad types of hyperlipidemia, primary and secondary. Primary hyperlipidemia holds a genetic predisposition. The body either makes too much cholesterol or cannot get rid of it fast enough. Secondary hyperlipidemia is acquired throughout a person's life through unhealthy diet, medications such as amiodarone or corticosteroids, alcohol use, or other chronic illnesses such as hypothyroidism, chronic kidney disease, or diabetes. If left untreated, hyperlipidemia could lead to plaque buildup in vessels, causing the patient to be at higher risk of myocardial infarction, stroke, peripheral vascular disease, hypertension, and more. We're going to jump right into our case study. This is Mr. G. Mr. G is a 47-year-old Hispanic male who presents for his annual physical. He is overall healthy with no concerns today. He wants to go over his labs and possibly discuss a cardiac scan. He has a history of hypertension, which has been diet controlled. He is not on any prescription medication, and he exercises regularly. He does eat fast food for breakfast and lunch. However, he tries to get healthier options such as egg whites or salads when he can. His dinner is usually at home and includes baked or air-fry foods. He does not drink any soda and tries to consume 60 to 70 ounces of water daily. His family history is unknown since he is adopted. This is his review of systems, which was negative. His vitals look great except for some elevated blood pressure reading, and his physical exam was unremarkable overall. Mr. G had his lab work done prior to today's visit. His overall lab work looks great except for his lipid panel. Comparing it to lab work from the year before, there's definitely a change in his cholesterol level, HDL, LDL, and triglycerides. Normal lab values for total cholesterol is less than 200. HDL, the healthy cholesterol, should be above 60 optimally. LDL should be below 100 or below 70 for patients with diabetes, and triglycerides should be below 150. As you can see, Mr. G has some work to do. So let's now jump into some clinical guidelines so that we can give Mr. G treatment options and use shared decision-making to develop a reasonable plan for him. Atherosclerotic cardiovascular disease, or ASCVD, is an accumulation of plaque in the arteries and includes conditions such as coronary artery disease, cerebrovascular disease, peripheral artery disease, and aortic atherosclerotic disease. The ASCVD calculator is a tool used to calculate a patient's 10-year risk for having a cardiovascular event, such as a heart attack or stroke. It is intended for patients aged 40 to 75 who do not have ASCVD, have an LDL less than 190, non-diabetic, and not on a statin. The calculator takes into account a patient's age, gender, race, smoking status, blood pressure, total cholesterol, HDL, LDL, history of diabetes, and if they are on treatment for hypertension. There are 4 risk categories: low, borderline, intermediate, and high. For those patients who have an intermediate risk or higher, a statin is indicated. The tool can be accessed as a direct link that is listed, or can be downloaded as an app on your phone. To help determine if a patient should be started on a statin, there are risk-enhancing factors. These include family history of premature ASCVD, primary hypercholesterolemia with an LDL of 160 to 189, metabolic syndrome, chronic kidney disease, chronic inflammatory disorders, premature menopause, pregnancy-associated conditions such as preeclampsia, high-risk ethnicities such as South Asian, and lab biomarkers. The presence of any of these risk factors help to identify a higher risk state and can be used to support a decision on whether to start statin therapy or intensify statin therapy. This slide represents the algorithm for primary prevention. As you can see at the very top, no matter which age group, it is important to always emphasize adherence to healthy lifestyle. Important takeaways from the primary prevention algorithm include: primary prevention is for those patients who do not have ASCVD. For all patients, education on a healthy lifestyle, including diet, physical activity, and tobacco use, is paramount for preventing and reducing ASCVD risk. For those patients aged 40 to 75 who have an LDL between 70 and 190, ASCVD risk should be calculated and a risk discussion should be had. Those who have an LDL equal to or greater than 190 should be started on a high-intensity statin. Adults with diabetes should start a moderate-intensity statin and progress to a high-intensity statin if there are risk-enhancing factors. Secondary prevention are for those with ASCVD. It is divided into not very high risk and very high risk. Patients who are very high risk have a history of multiple major ASCVD events or one major ASCVD event with multiple high-risk conditions. Major ASCVD events include recent ACS within 12 months, history of MI, history of ischemic stroke, symptomatic PAD. High-risk conditions include patients aged greater than or equal to 65, heterozygous familial hypercholesteremia, history of CABG or PCI outside of a major ASCVD event, diabetes, hypertension, CKD, current smoker, history of CHF, and persistently elevated LDL despite maximum tolerated statin therapy and Zetia. Here is the algorithm for secondary prevention. Some takeaways from this algorithm include: all patients with clinical ASCVD should be on a high-intensity statin if they can tolerate it. The goal is to lower LDL by at least 50% and or less than 70. The provider may add Zetia if the patient is on a statin and the LDL is still greater than 70. If considering adding a PCSK9 inhibitor, add Zetia before adding this. Statins are divided into low intensity, moderate intensity, and high intensity. Low intensity statins lower the LDL by 30% or less. Moderate intensity statins lower the LDL by 30 to 49%, and high intensity statins lower the LDL by at least 50%. The medications in bold have been assessed in randomized control trials and have shown to reduce major cardiovascular events. Besides statins, Zetia, bile sequestrants, PCSK9 inhibitors can be used. Zetia is the most common non-statin that is used. Occurrence for side effects is low, and it lowers the LDL levels by 13 to 20%. Bile sequestrants can lower LDL by 15 to 30%. They do not cause systemic effects, but they can cause GI complaints. They can also cause severe hypotriglyceridemia when fasting triglycerides are greater than 300. PCSK9 inhibitors are good at lowering LDL and are well tolerated. These medications can all be used in combination with a statin. I'm now going to give you guys a few seconds to look over this table that summarizes treatment, goals, and follow-ups for different clinical scenarios. Using the ASCVD calculator mentioned earlier, we can calculate Mr. G's 10-year risk of developing ASCVD. According to the calculations, his risk is 7.6% or considered intermediate. According to the primary prevention algorithm, a risk discussion is warranted. We can also consider checking the Agatston coronary artery calcium score. This measures coronary atherosclerosis. An increased score is associated with a higher risk for cardiac events. When discussing treatment options with Mr. G, it is important to recognize some barriers to following practice guidelines. These barriers include affordability of medications, adherence to medication and treatment plan, failure by providers to stay up to date on changing guidelines, and provider time constraints. Some ways of overcoming these barriers include the Walmart's $4 list, which can be a more affordable option for patients needing statin therapy. They offer simvastatin 10 mg, 20 mg, and 40 mg at a lower cost. Statins, especially high-intensity statins, have been known to cause muscle aches in some patients. One way of overcoming this barrier is to perform a statin re-challenge or prescribe a different statin to the patient. It is also noted that different regimens, such as a low-dose statin plus a different cholesterol-lowering medication, can be more tolerable for the patient. Other barriers are associated with providers failing to stay up to date on the latest guidelines. This can be due to the length and complexity of the guidelines. Algorithms, such as the ones mentioned earlier in the video, can be quickly found online and show guidelines that are easier to follow and require less time by the provider. A sample on how to document in the EMR that demonstrates our care was evidence-based is shown on the screen. We use the AHA guidelines to emphasize the point that we would like to recheck Mr. G's lipid panel in 4 to 12 weeks, just as they suggest. After starting Mr. G on a statin, he has come back to the office for his 3-month follow-up. He states that he has been involved in an exercise program and has changed his eating habits. This has resulted in a 20-pound weight loss. A CAC score of 89 Agatston units was measured after his last visit. This places him at low intermediate risk for atherosclerotic disease events and warrants a risk discussion. We had this during his last visit, and we agreed to initiate a statin. We will now advise him to continue this medication because the literature supports our decision. We rechecked the following labs before his visit. His lipid panel showed a total cholesterol of 196, an HDL of 42, an LDL of 128, and triglycerides of 147. We are happy with his overall response to the medication and think with further diet and exercise, Mr. G can continue to improve in his overall cholesterol status. We will recheck his lipid panel annually to monitor his progress. The AHA guidelines suggest checking lipids 4 to 12 weeks after statin initiation or dose adjustments, and then monitoring the lipid panel every 3 to 12 months as needed. I will now give you a couple minutes to jot down your answers to the following questions.